Okay, so good morning everyone. Today we will continue with our presentation on the contrast media in radiology. Last week we talked about the classification of contrast media into ionic and non-ionic and water soluble and the different types of the contrast medium. We started to talk about the adverse reactions that can be seen with contrast media, and we were talking about last thing is about nephrotoxicity. So we'll continue from there. The recent review suggesting that the incidence is 5% nephrotoxicity happens. Most commonly, it is in the form of acute renal failure that is transient and occurs after administration of the contrast medium. We give contrast media. If we follow the patient, there will be some elevation in the serum urea and creatinine for few hours, maybe days, and then usually everything goes back to normal. It's not symptomatic. The predisposing conditions are pre-existing renal impairment, which is up to 90% is the predisposing condition. Diabetes in 50%, of course, dehydration, age, large doses of contrast media that we use in, especially in angiography. We said we usually give a dose of 1 to 2 cc per kg in the amount of the injection rate is about 1, maybe 2, maybe 3 cc per second. However, in angiography, we can go up to 5 cc per second.
CC?
Yes, 5 to make it very good angiographic opacification of the vessel, very large bolus dose in a fast injection rate, so it can predispose to renal abnormality. Multiple myeloma is also a predisposing factor, and some drugs. So the mechanism is usually impaired renal perfusion, which can be due to cardiotoxic effect, peripheral vasodilatation, renal vascular bed changes, RBC rigidity, pre-dehydration, and osmotic diuresis. Also, the contrast medium might cause glomerular injury due to impaired perfusion and hyperosmolar and chemotoxic effect. And as we said, all contrast media that are used nowadays are hyperosmolar. The low osmolar and the hyperosmolar contrast media, both of them are hyperosmolar. The only one is something called iotrolan, is the isoosmolar, but it's not used in daily practice because of its price, and it is high viscosity at room temperature. We need to warm it before we give it to the patient. Okay, so even the low osmolar contrast media are hyperosmolar compared to the blood. They are just less hyperosmolar than the HOCM. Okay. Also, tubular injury like cytoplasmic vacuolation. In 43 clinical trials, there was no difference between LOCM and HOCM regarding nephrotoxicity. Okay, so if you are asked what to prefer to prevent nephrotoxicity, low osmolar or hyperosmolar contrast media, there is no difference. Okay, in matter of nephrotoxicity, other things that are different. Neurotoxicity. The contrast medium may cross the blood-brain barrier. When is the blood-brain barrier is damaged? For example, infection, infarction, tumor, anything that destroys the blood-brain barrier takes enhancement. That means that the contrast medium crossed the blood-brain barrier. Okay? Because if it does not cross the blood-brain barrier, it will not cause enhancement. The lesion will not enhance. LOCM is better than HOCM. Low osmolar contrast media is better than hyperosmolar contrast media, which may have some chemotoxic effect. IV contrast media may provoke convulsion in patients with epilepsy of cerebral tumors. Don't panic when you give contrast. If you give contrast medium to someone and he gets convulsion, it's due to the contrast media. Don't panic. You just give anticonvulsant like diazepam and that's it, nothing else. Okay? And the convulsion may occur due to the cerebral hypoxia. When we give large dose of contrast medium, this will result in temporary cerebral hypoxia in a patient with already have brain tumor or epilepsy. It may cause convulsion, okay? Thyroid, what about the thyroid function? We are giving a huge dose of iodine. As we said last time, the average contrast medium, the iodine dose that we give is about 2,000 times the amount of iodine in the human body. Okay, so it's a huge dose. So this will result in thyrotoxicity, may occur in patients with non-toxic goiter or exacerbate those with pre-existing thyrotoxic symptoms. If he has thyrotoxicity, may exacerbate the symptoms. If he doesn't have thyrotoxicity, it may lead to thyrotoxic crisis. Okay. Now, the reactions, the allergic reactions, we have two types: the anaphylactic and the idiosyncratic. What's the difference? Anaphylactic is dose independent. If you give 1 cc, you give 100 cc, it will happen with the same severity. Yani, you don't give a test dose for anaphylactic reaction. If you give 1 cc, if the patient has predisposition to anaphylaxis, it will happen. If you give 100 cc, it will happen. Idiosyncratic, it is dose dependent. The more you give, the more likely it will happen. Okay? So you can, like, maybe some testing for it. So, according to the severity, can be classified into major, intermediate, and minor. Minor reactions, not uncommon. They happen every now and then. Intermediate also might happen, but thank God, major reactions, usually, it's rare. Okay? I hope no one sees a major reaction for life. Fatal reactions, the major ones, there is no difference in the mortality rate between the ionic and the non-ionic contrast medium. As we said, the only difference is that the ionic, we cannot use it intrathecally. The ionic, we don't give it for myelogram. Okay? May be preceded by trivial event or may occur suddenly. In majority of patients, they are over 50 years old, and the causes of the fatal reactions are due to pulmonary edema, respiratory arrest, consumption coagulopathy, and bronchospasm, severe bronchospasm. Okay? So, within 20 minutes of injections, most of them, of the fatal reactions, they occur within the 20 minutes of injection. So, it is advisable to keep the patient in the department for at least 20 minutes after imaging, after injection, just to be sure that everything is okay. Okay? It's independent of the dose. Anaphylactoid reaction, as we said. Prior sensitization is not required. يعني ممكن patient يجي previous imaging, everything is okay and normal, or no previous imaging, no use of contrast medium, no previous allergic history, nothing. Everything looks okay. You give the contrast and you have a fatal reaction or very severe idiosyncratic reaction. It's just your luck, nothing else. يعني مجرد حظ. Okay? They do not consistently recur in a given patient. And the thing is, if the patient did it another time, it might not happen. يعني مو شرط إذا صار مرة every time it will happen. ممكن once happen and the next time it will not. Okay? Non-fatal reactions include flushing, metallic taste, nausea, sneezing, cough, tingling. They are common. They happen like a lot every day, several times. However, they are mild and transient, and they will go away by themselves. They have lower incidence with low osmolar contrast medium, sometimes perennial burning, feeling of incontinence. It's more in women, can have some urticaria, and neurotic edema, mostly to the face, and up to 3 days, and may have delayed onset. Sometimes the patient might call you the second day and say, I have some sort of puffness of the face or something. It's just some form of non-fatal reaction to contrast medium. Sometimes necrotizing skin region might happen, which are rare, okay, especially in SLE, systemic lupus erythematosus. Bronchospasm, they are relatively more common, some mild to moderate bronchospasm. Usually they have a history of asthma or a use of beta blockers, mostly subclinical and less with low osmolar contrast medium. Non-cardiogenic pulmonary edema during the acute anaphylaxis or hypotensive collapse, and increased capillary permeability. Due to the use of contrast medium, there will be fluid will move from the intravascular compartment into the extravascular compartment, resulting in pulmonary edema. Okay? Hypotension and abdominal pain also may happen. They are usually mild, the hypotension, and the abdominal pain may be a symptom of anaphylactic reaction or vagal overactivity. Okay? And keep in mind, usually in females about 15 to 25, 30, I swear to God, it always happened like that. Okay, they are more prone to develop some sort of chest tightness, some metallic taste, some fainting, like a vagal or vasovagal attack or something like that. Don't be terrified. They usually do very well by themselves. Just check the blood pressure, check the pulse, take some auscultation of the chest, everything is okay. Keep her waiting for like 15, 20, 30 minutes, everything will go away by itself, don't worry.
So the patient is asthmatic, shall we give contrast or?
As we said last time, the only absolute contraindication to contrast is previous contrast allergy. Otherwise, everything is relative contraindication. According to the case, can it be solved without contrast? It's even better. You need contrast, you take your precautions, you follow the patient, and I'll give you the whole management scheme, and it depends on the clinical case. Only previous contrast allergy is an absolute contraindication for contrast. Even renal failure is not an absolute contraindication. You can give contrast and shift the patient to dialysis. You arrange an appointment for dialysis, do CT scan, give contrast. In fact, when he has a dialysis appointment, it's the best. You can give any dose you want. هو راح يروح dialysis أصلاً يعني. So you have nothing to worry about. Okay? So if we classify the usual reactions, they're to mild, moderate, and severe, you can see that mild, from my personal experience, nausea and vomiting are very common. Okay? Some pallor, coughing and dizziness also are a little bit common. Moderate, well, they're less common. I saw it few times, like some persistent vomiting or headache. Okay, mild dyspnea is also a little bit common. Severe, inshallah, no one see it at all. Like arrhythmia, hypotension, pulmonary edema, seizure, and syncope are there. We might be careful about that. Regarding the chemotoxicity of the contrast, that's not allergy. I mean, the chemical composition of the contrast medium, does it have any toxic effect chemically? Okay, because the hexaprex, we said it is the ionic form of low osmolar contrast media. It's the only one that is ionic. We cannot use it intrathecally, and one cannot use it for intracoronary injection in cardiac catheterization. Why? Because it is an ionic form, so it will be separated into anion and cation. The anion is the iodine that we use for imaging, which is good for us. The cation is the problem. It's useless. It will bind with whatever electrolytes see in the bloodstream. For example, calcium. In the heart, it will lead to calcium, hypocalcemia. It will result in cardiac abnormality. So be careful with that. And thank God it's not very much available nowadays. Also, you cannot use it for intrathecal, as we said, because the cations are the more toxic than the anions, okay? Even isoosmolar contrast medium have tendency to change RBC morphology. You know, we said there is only one isoosmolar, and we need to warm it to the room temperature before injection. Even that can affect the shape of the red blood cells. So it's not like very safe. It's just safer, okay? Regarding the prophylaxis for adverse reactions, we have a lot of discussion on that. Every day we have a lot of patients that have some sort of allergic symptoms to no one knows what. First of all, pre-testing is disfavored because it will not protect you from anaphylactic reactions. We said anaphylactic reaction can happen with 1 cc, with 100 cc. So pre-testing is not very much beneficial. Pre-treatment with steroids, if the patient had previous reactions or at risk, usually the recommended dose is methylprednisolone 32 milligram orally 12 and 2 hours prior to the procedure. Okay, better to use a low osmolar contrast medium, which you normally use. No, it's the standard contrast medium, or prednisolone 50 milligram 13, 7 and 1 hour before the study. So if there's a significant risk of having a reaction, you prepare the patient 24 hours before that. Using this, it will give...
Just like in asthma, we can give...
Yeah, exactly.
Pretty soft.
Yeah. And the funny thing is sometimes patients already asthmatic and comes, I have asthma, I use steroids. So you don't need to be afraid. Just give the contrast and be careful. That's it. If the patient has previous moderate or severe reaction, you might think of changing the procedure. As we said, the only contraindication to contrast medium is previous contrast allergy. Okay? If history of minor reaction, you give diphenhydramine, that's the alarmine, antihistamine, 1 tablet per hour, 1 hour before the study. Most authorities restrict steroid pre-treatment to patients in whom previous idiosyncratic adverse effects reaction to contrast medium has moderate or severe. If they have moderate or severe contrast medium reaction, the use of steroids is not very well accepted in general. What about emergency administration of contrast medium? Someone who has some emergency event, like RTA, for example. If patients at high risk, when the oral medication is not possible, give 200 milligram hydrocortisone IV immediately, and every 4 hours till the procedure is completed. So, before imaging, you just give 200 milligram IV, and then every 4 hours. Because it's fast acting. Not methylprednisolone. Methylprednisolone is slow acting.
And not possible to take oral.
Yeah, it's not possible to give. Patient is in RTA, for example, comatose, unconscious, bleeding, be considered for surgery, whatever.
Why we give steroid?
In cases of patient unconscious, you don't know whether it is allergic or not. What you do, you give cortisone, 200 milligrams. It will cause no harm at all. It's fast acting. Okay, it might protect you from some protect the patient from some allergic reactions. Okay, and believe me, I found this policy of giving 200 milligram hydrocortisone personally. I use it a lot. 2 vials IV before imaging. Very nice results. If anyone who have sometimes patients, I had the previous, some urticaria, I have some bronchospasm, give vague symptoms. You don't know whether it's allergic or not. Even in daily practice, just give 200 milligram, wait 5-10 minutes, and then do the imaging. Everything will be okay. I've done it a lot, and it gives very nice results.
Diphenhydramine use it to the unconscious patient.
IV.
By itself unconscious diphenhydramine.
Again, sorry.
By itself, patient.
Comatose patient.
Comatose patient, and using diphenhydramine or other that cause affecting the conscious level.
We said that for the emergency cases, you use cortisone. You might use alarmine. Okay. Pre-treatment with antihistamine has no benefit. Pre-treatment with antihistamine, if the allergic reaction occurs, you can give. Before, it has no benefit. Okay, keep that in mind. 3 times increase the incidence of flushing, as you were commenting now. So, change of contrast medium to locum, it has very nice effect. Most important factor is just use low osmolar contrast medium. Everything will be, most of the times, it will be okay. Reduction of patient anxiety and apprehension is also needed. Few slides about the management of the side effects. This, I have no way of explaining it. You have to just memorize it. It's just management of adverse reactions. For example, in nausea or vomiting, make reassurance, retain IV access, give some antiemetics if needed. Okay, that's it. Mild scattered urticaria, also routine testing is not necessary. IV access should keep in mind to don't remove the cannula once the patient is off the table. Ask him to stay with the cannula for as long as possible until the report is ready, if you are reporting like immediately. Okay, as long as possible, because you don't know whether the reaction will happen. You will need the cannula. Okay, it might be life-saving. Also give chlorpheniramine 10 to 20 milligrams, so slow IV injection. Severe generalized urticaria, the life-saving thing is the IV access. It will save the life. Okay? Give IV antihistamine with IV hydrocortisone of 100 milligram. Mild wheeze also be sure to have a IV access, 100% oxygen at 10 to 50 liter per minute with beta 2 agonist, salbutamol, maybe by nebulizer, and repeat as necessary. Okay? Hypotension with bradycardia, like some sort of vasovagal attack, raise the patient feet to make the blood flow more to the brain with 100% oxygen and large IV access, ECG monitoring, oximeter, IV fluid, IV atropine, and call the CPR if no response, the CPR team. I mean, well, it's, CPR team should be available in every hospital 24/7.
احنا بس نسوي رئيس patient feed.
Well,
شوية ضرب.
I hope we never need to use anything other than raising the patient feet. Inshallah, no one needs to use it at all because it's terrifying, you know, for us rather than the patient. If there is hypotension alone, again, 100% oxygen with rapid IV injection, blood pressure monitoring, ECG and oximetry, and if no response, you might go to dobutamine and dopamine. Okay. Now, what about the management of severe anaphylactoid reaction, like the real horror? IV access, rapid fluid, 100% oxygen, beta 2 agonist, and IV hydrocortisone, ECG, blood pressure monitoring, oximetry. If hypotension persists, give adrenaline and call CPR. Okay? Yeah. You can use IV or IM, both of them. In cases of shock, you might go for the direct IV injection. It can be used IV, don't worry. If the patient is unconscious, unresponsive, or collapsed, first of all, don't collapse. You
will collapse.
okay?
Collapse.
Don't panic. If you panic, you'll kill him. This is the most important thing. Okay? Keep calm, breathe, and focus. Call CPR with basic life support, IV fluid and oxygen and tracheal intubation. Use DC cardioversion if there is ventricular fibrillation, and IV adrenaline, okay? And hydrocortisone or the antihistamine. If no IV excess, then give adrenaline, IM. If you don't have an IV excess. That's why I'm telling IV access might be life-saving, okay? If you have seizure, maybe the consequence of hypotension, give 100% oxygen and, of course, some diazepam. Most of the times, diazepam will solve the problem within seconds. You should have a trolley, like a جماعة الإنعاش عندهم هذا الخزانة خلينا نقول, that contains the whole thing, even endotracheal tube and everything. Okay, you should have all these within this locker. Let's say every place should have it, because when you give contrast, everything of that might happen. You don't know. Okay, laryngeal edema. This is something to be afraid of. If it is mild to moderate, give oxygen and epinephrine. If it's moderate or severe, call for help, intubate and give diphenhydramine. Okay, and by the way, if it happens, if in any way you can arrange for cold air, use it. Cold air. It will relieve the edema. Okay, we use it with children a lot. Patients who have croup, you know, the epiglottic edema. You just make some ice, put it in a piece of cloth, شوية قماش, on his nose or mouth. It will help to decrease the amount of edema. يعني أي ثلاجة أو فريز, بس شوية خذ ثلج, حط طبق قماش وحطه على وجهه. Okay, it will help. Pulmonary edema, I think you all know the management. Dolma, you know. Digoxin oxygen Lasix morphine وكذا, the whole thing. Okay, extravasation injury, that's common. We use with CT, we use injection pumps a lot. Okay, so it's the vein might rupture, the cannula might rupture, resulting in subcutaneous injection of maybe 80, 100 cc of contrast sometimes. First, elevate the affected limb, apply cold packs, may need surgical consult. I didn't see anything that needs surgical consult. Usually it goes away by itself, okay? And conservative management. The most important is to reassure the patient. The patient will be terrified. Oh, my hand is swollen. Don't worry, elevate, and that's it. It will go away by itself, okay? Some things just keep in mind when you are using drugs for management of allergic reactions and different kinds of reactions. Antihistamine and corticosteroid don't mix in the same syringe. Okay? Corticosteroids are quite correctly slow-acting drugs, but still should not be withheld. Yani, you have an acute event, steroids are usually slow-acting. But that does not mean don't use a steroid. Use it, even if it's slow-acting. Use it. IV adrenaline is a dangerous drug associated with cardiac arrhythmia. It should not be used in minor reactions. مو تعجبك اللعبة وكل ما صارت reaction وطيتها adrenaline. It's not safe. Okay? Use it for moderate or severe reactions.
allergy دائما IM بس على هاي النقطة.
No, you can give it IM or IV. If the patient is shocked, he's hypotensive, he's bradycardic, IM will take like forever for it to start work. Go for the direct IV route. If there is some blood pressure and you have circulation, you can use it IM. Okay? Like to relieve bronchospasm, for example. You can use adrenaline. Okay? Few words about the contrast media in MRI. The MRI contrast media. How do they work? They should change or alter the rate of relaxation of protons within the tissue to produce differential enhancement. They change the way the protons move or relax in order to make the enhancement, the MRI enhancement pattern. Okay? So, what an MRI contrast enhanced image will appear in different sequences? What will happen? There are two types of contrast in MRI, the negative contrast and the positive contrast. We have negative contrast medium and positive contrast medium. If the T1 relaxation is more rapid, the image will be brighter on T1. That's the positive contrast. It will make the proton relax rapidly, fast, making them hyper intense on T1. That's the normal that we use every day, the gadolinium. Okay? It makes the proton enhance more rapidly. While the T2 based contrast medium, they will do the opposite. They will make what? The normal tissues will be dark in T2. For example, imagine the liver. You give contrast, the liver will be hypo-intense on T2. The lesion will appear more obviously. Okay, so that's a negative contrast medium. It's the opposite. Okay, يعني الكونتراست ميديم بالتي 1 يشبه الكونتراست ميديم مال السي تي. ايوداين ياخذ انهانسمنت ويطلع هايبر انتنس. بالتي 2 the negative contrast media are the opposite. The normal things will be dark and the abnormal يطلع اوضح. فهمت شلون؟
يعني هو الابنورماليتي يصير برايتر.
بس مو enhancement. It does not take enhancement. The normal tissues will be darker. Okay? هو يظل مثل ما هو. اي هو يظل مثل ما هو. Okay? So they are classified into three types: ferromagnetic, paramagnetic, and superparamagnetic contrast media in MRI. The ferromagnetic, they maintain the alignment with the field even when the field is removed. They are unsafe. They have some chemical problems, not used. We don't use it. The ferromagnetic. Paramagnetic, like gadolinium, the thermal energy within the tissue is enough to overcome the alignment made soluble by chelation. Given IM, maximum effect is on water molecules, increasing the signal on T1 by shortening the T1 relaxation time. Okay? They act on water molecules. They are affected by the tissue temperature, okay? And they are removed by chelation. They are put with something that makes the kidney excrete them. Super paramagnetic, like the ferrite, They are the aggregates of paramagnetic ions in crystalline lattice producing rapid dephasing, shortening the T2 relaxation time, decreasing signal on T2. They are less soluble, available only as colloid suspension. The super paramagnetic, they are T2 contrast image, not T1. Yani nowadays when we give gadolinium, we tell the technician, make me a T1 post contrast. When you give super paramagnetic, you say make me a T2 post contrast. Okay? The thing is, they take long time. They are colloid, so you just give them by IV and keep the patient waiting for like a few hours before imaging. They are very slow. Need some specialized centers and a little bit more complex to use. Both paramagnetic and super paramagnetics can be used as GI contrast agent, بس they should be made palatable. يعني طعمها يكون مقبول على الأقل. Someone can drink it. Okay, not delicious, but at least I can drink it. Okay. Regarding gadolinium, they are available with many chelating agents like gadolinium DTPA, which is the Magnavest, and Omniscan, and a lot of different trade names. All of them is gadolinium with something that chelates them. If the patient have impaired renal function, what will happen from contrast medium? Most common side effects, something called nephrogenic systemic fibrosis. Patient have renal failure. He will not have the allergic reaction that we see with the contrast medium. It's much safer, the gadolinium based. He will have something called nephrogenic systemic fibrosis, skin thickening and scleroderma, something like that. This is the thing, okay? So what's the indication of contrast medium in MRI? CNS tumors, especially small acoustic neuromas, spinal seeding from posterior fossa tumors, the demyelinating diseases, differentiate the acute from chronic plaques, accurate delineation of tumor margins from edema, discrimination of tumor recurrence from post-therapy fibrosis. However, that's not very accurate because some in the early stages fibrosis might take enhancement also. It depends on the duration. Discrimination of recurrent intervertebral disc prolapse from postoperative fibrosis, and the images must be obtained within 30 minutes because after that both of them will take contrast and you will not be able to differentiate. Also in cardiac and aortic imaging, contraindications, there are no absolute contraindications. Roughly they are the same or similar to contrast medium, but no absolute contraindication. You can give them to everyone. In pregnancy, contrast medium is not very well documented whether they are cause some do they cause congenital malformation or affect the child in any way? We don't have very strict data, so especially in the first trimester, try not to give contrast medium unless very necessary. Okay, the dose is 0.2 mil per kg, 0.2 milliliter per kg. Okay, in case of Magnavest. If you are using a low magnetic field, for example, an open MRI, that is 0.4, 0.3 Tesla. Okay, the standard MRI is 1.5, the one that we have here, and we have and everywhere else. There are some centers that are using 3 Tesla, few centers. If you are using low magnet, like the open MRI is like 0.3, 0.4 Tesla, you can increase the dose to 0.4 mil per kg. Okay? Slow administration, about 60 seconds for 40 kilo individual. Someone who weighs 40 kilo, you give it in 120 seconds. For 100 kilo, you can you reduce increase the duration to reduce the possible side effects, and it's only in about 3% of injections. I think we have few more minutes for GI contrast agents, which should be mixed readily with bowel content for even GI in contrast agents in MRI. Okay, you can use contrast agents for GI in MRI patients. They must be palatable. You must be able to taste them, not very bad taste. Okay, again, positive and negative agents. Positive agents like fatty oils and gadolinium, they act by T1 shortening. They appear white on T1. Okay? The disadvantages, why we don't use them, because the increased bowel motion artifact will be, with the bowel, the artifact will be more, because they are hyper intense on T1. Okay? So usually we give something like Buscopan to make the paralysis less severe and less frequent. Variable effects with pulse sequence and contrast, concentration and cause confusion. They are expensive, but nowadays it's much less expensive. It's more available. I think جماعة مستشفى جين they sell oral contrast for MRI. Okay. Negative agents like ferrite and barium sulfate, they cause T2 shortening. So they appear black on T2. Okay? Again, like we said. Because you are giving ferrite, you are giving hadid, iron to the patient. Iron makes low signal in MRI. Okay? So when you give it orally, the GI will be darker. Disadvantages: high concentration cause image distortion and blurring, and required dose of ferrite is potential lethal, and it's unpalatable. Very bad taste. Okay? I think we can take like just 3 slides more and we'll finish the whole thing. Contrasting agents in ultrasound. There are some contrast agents that are used in ultrasound. They allow the evaluation of vascular structures. They are bubbles less than 7, sorry, not millimeter, micrometer. This is wrong. 7 micrometer, it's 2 to 5 micrometer, and on average they must be used to pass the pulmonary filter. The thing is that I can't give the normal saline. Normal saline has bubbles in it. Okay? Why cannot we use it? Because these bubbles will not survive the pulmonary filter. In the lung, they will be trapped. Okay? So we need to use something that preserves the bubbles until they cross the lung, so that it can go to the lesion and enhance and make contrast enhancement. So bubbles this size can remain intact for a few seconds in the blood, and they use encapsulation. They encapsulate the vessel, the bubble, sorry, okay, to last more than 5 minutes, so that it can move in the circulation and we can see the contrast enhancement. Example, there are some few contrast agents like Levovest and Ecovest and Sono RX. Levovest bubble enclosed in palmitic acid in galactose solution, while Ecovest also in galactose solution cannot pass the pulmonary filter used to assess tubal patency. You can use it to make a sono histogram. You can make histogram by ultrasound. Okay. New agents. There are something in ultrasound. There are few agents like ultrasound tissue-specific ultrasound contrast agents. Contrast agents that go to specific tissues, not everywhere. They go to specific parts. Okay, they become taken up by, for example, reticuloendothelial tissue like liver and spleen. Okay, can adhere to specific sites like DVT, for example. If you are not sure if there's a DVT or not, you can give it. Go to the thrombus, to the clot, and they adhere there and make it more obvious for us. Like, for example, Sonovest, Sonozoid, and Levovest. Okay, and this will be our presentation on the contrast medium in radiology. I hope we covered as much as possible. If you have any questions. Good.
In contrast in ultrasound, why nowadays we don't use it yet?
It's used everywhere. Here it's not used. Yeah, it's used everywhere.